Now, from the younger women, problems of the younger women, we straight away move to women of elderly age group who face these problems. Now, friends, any cytology event is incomplete without paying tributes to Dr. George Nicholas Papanicolaou and his wife Andromache Mavrogeni. The research and educational activities of this scientist couple gave birth to cytopathology as the subspecialty of pathology, and this couple was bestowed with many awards and accolades for their contribution to this field. But the highest honor came in when the scientific community at large decided to name cervico-vaginal cytology as the Pap smear. The revolutionary discovery of the and systematic implementation of the Pap smear in the mid-20th century led to a historical reduction in the death rate from 25 to 10 per lakh women, and this is when the WHO announced that cancer cervix was a preventable disease. Preventable but yet not prevented is the reality today, because we know there are pockets all over the globe where the incidences are very high. When we are talking about cervical cancer control, we mean secondary prevention. And secondary prevention is possible because cervix is an easily accessible organ. It has the propensity to exfoliate normal and abnormal cells, which can be, and these abnormal cells can be picked up and studied. And this disease has a very prolonged natural history of 10 to 15 years, during which there are changes in the epithelium in the form of cervical intraepithelial neoplasia. Now, screening for cancer cervix aims to detect these precancerous epithelia in an apparently healthy population through systematic administration of a simple and safe test to all women belonging to a specified target age group. The WHO recommends screening of women between 30 to 49 years of age, because at this age we all know that the probability of harboring the CIN2 and CIN3 lesions that are true cervical cancer precursors is very high. The frequency of screening in the screen negative women depends on the screening test being used and the resources that are available within that country or in the program. Too frequent screening is not recommended, and the minimum interval between 2 rounds of screening should be 5 years, as against our conventional teachings that Pap smear should be done annually. No, the trends have changed. The screening can extend to 10 years for programs with limited resources, or if you are using a test like HPV DNA test, which is highly sensitive. Overall, for the rural women, even once a lifetime screening around the age of 40 years, especially in the peripheral areas, can reduce cervical cancer incidence by 30%. Now, cytology in the form of a conventional Pap smear is an age-old screening test. We all know that, but it is highly subjective and provider dependent, with varying performance between laboratories and cytologists reading the smear. Even then, systematically collected cells from the squamocolumnar junction and from the transformation zone, well fixed, well stained, is still the best method to screen women belonging to the low and middle income countries, and has a high sensitivity for detecting CIN2 and CIN3 lesions. Now, to achieve this high sensitivity for high-grade lesions, you have a variety of devices that have come into the market in the forms of brooms and brushes and spatulas that sample the squamocolumnar junction and the transformation zone very well. But adequate sampling also heavily depends on the nature of the erosion. For example, if you have an erosion like this, you will collect your spatula or your brush will definitely collect cells from the squamocolumnar junction as well as the transformation zone. But if you have a circumoral erosion like this one, which is very large, your device will move within the endocervical glandular area, and what we get in the smear are only endocervical cells with very few squamous cells, and then the smear is unsatisfactory for evaluation. Or if your spatula is scraping such a hypertrophic mucosa with purulent discharge present on the surface, again the smear will be unsatisfactory for evaluation, because we are going to see only inflammatory cells in the smear. In such a situation, because I'm talking in a gynecologist group, I can say that if this patient of yours belongs to your private clinic or even in your clinical OPD, and you are sure that she will return back, you advise a course of antibiotics and ask her to come after 4 to 6 weeks. And after that, you will see that the cervix is pretty clean, and you can visualize the squamocolumnar junction and the TZ, and you can collect a very appropriate smear. Also, the device that you are using should have the ability to cover wider areas of the transformation zone, because we know these lesions can occur farther away from the squamocolumnar junction, and the same lesion can harbor areas of CIN1 to CIN3. So you need to sample these dysplastic areas no matter how far they are. In case of atrophy, when locating the cervix is not possible or it's very painful, advise application of an estrogen cream for a week or two, and then collection of a pap smear becomes easier and accurate. Now, friends, we need to remind ourselves that a screening test is not a diagnostic test, because many a times I get requisitions from the gynecologist for offering a diagnosis on the smear. No, it's a screening test. Secondly, in a conventional pap smear, thick and thin areas while smearing the material are just unavoidable. It cannot be standardized. That is the difficulty. And thirdly, it is inevitable to miss few abnormal cells lying in a gamut of 3 to 5 lakh cells in the smear. At times, it is like trying to find a needle in the haystack. These limitations of cytology are responsible for the high false negative rate of 14 to 33% in varying with the laboratories. Given the challenges of implementing a high-quality pap smear services combined with lack of resources and trained manpower in developing countries, the WHO in 1986 proposed an alternative strategy for downstaging of cancer cervix. This included a simple per speculum examination for any signs of cancer. This test of visual inspection of the cervix has the advantages that it can be performed by any paramedical or a minimally trained paramedical or medical personnel. Results are available immediately, and it has the potential for greater population coverage and immediate referral for treatment. Therefore, the Alliance for Cervical Cancer Prevention has researched extensively on these variations of visual screening methods. Magnification has been applied, so you have the VIAM, where you can see the cervix better under good illumination and with a magnifying lens. And later, the WHO developed a generic protocol of see and treat approach. 1 minute after application of 5% acetic acid to the cervix, the appearance of a well-delineated dense acetowhite area abutting the squamocolumnar junction and within the transformation zone of the cervix is considered as a positive test. With Lugol's iodine, a negatively stained yellow to mustard-colored epithelium is taken as a positive test. But mind well, these tests are suitable only for premenopausal women in whom the cervix transformation zone is fully visualized and is on the ectocervix. And these tests are not very ideal for postmenopausal women in whom the squamocolumnar junction is not fully visible or has been receded up into the canal. Research using these tests concluded that no doubt the execution of these alternative strategies does help to maximize screening coverage, but the general paraphernalia required to take the screening services to the doorstep of rural women poses challenges similar to those of implementing any pap smear program. Cost of training of paramedics can offset the cost of implementing pap smear in rural areas. And an important conclusion was that VIA can still be a good test, but it is a good pre-selection test for PAP so that the costly PAP test could be used judiciously. At the turn of the century, while the Eastern world was struggling for an alternative screening strategy, in the West, the PAP smear faced adverse criticism in the world's press. The frequency, severity of litigations, claims involving cervical cytology increased dramatically due to the false negative reports of the pap smear, and the need for automation in reporting of cells was felt. But the prerequisite was that the smear should be monolayered, and this prompted the development of a thin layer cytology or the liquid-based cytology. LBC is the first technical advancement in cervical cytology. in more than 50 years, and it offers an improved test specimen collection using a cytobrush. You just have to rotate this cytobrush in a clockwise manner 5 times, drop the head of the brush into the vial, which contains a weak fixative, and label the vial and send it to the lab. So collect, drop, and send the vial. The cells in this vial, they remain very nicely for 4 weeks if the vial is kept at the room temperature, for 6 months if it is refrigerated. The additional advantage is that this same sample can be used for a reflex HPV DNA test for triaging a case with atypical squamous cells. The differences are obvious to the naked eye. The cellular material is evenly distributed within a 13 millimeter diameter as compared to a conventional pap smear, which has 2/3 areas of the slide smeared with the thick and thin material. Enhanced nuclear and cytoplasmic details results in better ability to determine parentage of these cells and help to detect borderline nuclear changes very comfortably. Now, does LBC improve the quality of cytology services? Yes, it was observed that sensitivity is up to 12% better with LBC as compared to the conventional pap smear, but there was no difference in the specificity of LBC and conventional pap smear. Importantly, there was a significant decrease in the number of inadequate samples from almost 9% to 1%. In our own study, showed a 3 to 5% increase in positivity rate with LBC specimens, and when HPV DNA test was used as the gold standard, the accuracy of the test increased by almost 17 to 18%. And when colposcopy was the gold standard, the accuracy improved by 3 to 5%. Now, will LBC be clinically effective? The American College of Obstetrics and Gynecology was of the opinion that achieving high coverage of the target population and having regular pap test is most responsible for decreasing a woman's risk of developing invasive cancers rather than banking on new processing methods. Now, better understanding of the pathogenesis of cancer cervix in the early 21st century led to the realization that biologically, HSIL is a different entity and can develop de novo as a result of persistent HPV infection with high-risk viruses, especially the 16 and 18 types. Therefore, it was proposed that molecular detection of HPV DNA better identifies women at risk for developing invasive cancers. Now, the HPV DNA test is a highly sensitive test, reproducible, and it is provider independent. Its sensitivity to detect HSIL is up to 95%, but it is less specific than cytology. Until recently, it was being used as a triage test or a surveillance test. Now, what is a triage test? When you add a second screening test to the existing one, which either has a low sensitivity or it has a low specificity or vice versa, then in that case you get more information if you add a triage test. Now, for detection of the HPV DNA, we have the hybrid capture 2 test for this, and it generally detects 14 high-risk HPV viruses, and it detects the viral load. The cutoff point is for the test is 0.28. Any viral load above this is considered as significant. Now, before moving in to the understanding of HPV DNA test, we need to understand the qualitative differences between HPV test and cytology, be it a pap smear or LBC. Now, the HPV DNA test just detects the culprit virus, whereas the pap smear detects the crime committed by the virus. But if you want to know whether the viral DNA has integrated into the host genome and has turned the epithelium dysplastic, then you need to go for an additional test or triage it with cytology. In that case, you collect a pap smear. So now, ironically, HPV test is a pre-screening test for the more confirmatory pap test. The next test for both these streams is the same, that is colposcopy and directed biopsy. Now, currently, HPV DNA test is the primary screening test for many developed countries like Australia, America, and some of the European countries who have adopted to this test as the primary screening test. And this test is also being done on strips that are available on self-obtained samples. So you just introduce the strip into the vagina with your own self, and then you can read. So that is so well advanced. And these tests close the lights, are going on currently in many developed countries. Now, sending all HPV positive women to colposcopy may overburden the services and cost of screening. So, co-testing has been suggested, that is, you do both pap smear and HPV DNA test is the preferred screening strategy for women 30 to 65 years of age. And below 30 years of age, HPV DNA test is not advised. So, doing co-testing not only lengthens the screening interval, but it also has the potential to provide improved clinical and economic outcomes. Now, this co-testing is more rampant in the African countries, where they are doing a lot of outreach activities and conducting camps, because the incidence is 35 per lakh women. So here what they are doing, they are going to the periphery, collecting pap smear. At the same time, the same sample is being used for HPV DNA test using point of care tests. And what are these point of care tests? They are sort of rapid tests that give results in a time period of an average of 2 hours. And these tests, they are popularly known as the Care HPV Gene Expert Servista, and so on and so forth. So you get the results very fast, and these tests, they detect pooled high-risk HPV viruses, but genotyping is not available for types 16 and 18. The test platform that is available in many low-resource countries is the same as the one used to detect MDR tuberculosis. So now we all know that nearly all cervical cancers are caused by HPV infection, but only a very small number of women who have high-risk HPV test positive will go in for invasive cancer. For example, in US, now more than 20% women are positive for high-risk viruses, but less than 0.5% will develop invasive cancers. In such a situation, a triage test again comes into play. And because cytology and VIA are highly specific tests, they are the best triage tests for the highly sensitive HPV DNA test. Or you can do triaging with higher molecular testing in the form of genotyping for HPV 16 or 18, or by detecting the HPV mRNA oncogenes, that is E6 or E7, can be done before referral to colposcopy. Now, this ABOT and the COBAS high-risk HPV test, they are good for detecting a pooled detection of 14 high-risk viruses, and simultaneously in the same test, they also provide genotyping for type 16 and 18. Now, we have these PRETECT HPV and the APTIMA HPV test, which detect the mRNA proteins, that is the E6, E7 proteins, which tell you that there has been integration of the virus into the host genome. The PRETECT test detects the E6, E7 for these 4 types, that is 16, 18, 31, 33, and the APTIMA has a larger number of viruses, high-risk viruses that can be detected with their E6 and E7 proteins. The latest is the DH3 HPV assay, where both RNA and DNA proteins can be detected, and this is again a hybrid capture based technique. It is very robust. It does not require any hi-fi laboratory settings or a very closed protective environment. It is a very open and sturdy test, and a lot of research is being done on this. But these APTIMA, PRETECT, COBAS, ABOT, they are already, they have finished their clinical trials, and they are being used in the Western world, and also in India. A lot of research has been done by ICMR. And they are proposing these tests. Now, detection of the E6 oncoproteins can be done using liquid-based cervical cytology specimens and by doing immunocytochemistry, either on the smear, LBC smear, an additional smear can be made from the same vial, or you can prepare a cell block from the sediment and then use it just like histopath sections to detect the Ki67, which is a proliferation marker, or a P16, which is a surrogate marker of integration of viral DNA into the host genome. And this dual staining has a very high positive predictive value, and then it avoids the unnecessary referral for colposcopy and unnecessary invasive investigations. Now, there are these rapid tests coming on, which is the Onco E6 cervical test. It is an office test, and our life is really going to be easy if we get it in affordable prices in the future, where the gynecologist can literally take a sample, do a dip stick type of test, and tell you there and there whether E6 proteins are present or not. We have, this is also a story which is 5 to 10 years back, and we have done a case in using these strip test when the company people were with us. So friends, a screening test, whether cheap or costly, is only one component of cervical cancer screening program. Community mobilization for increased participation, training of all levels of service providers, ensuring further assessment and appropriate treatment of screen-positive women, and follow-up are equally important. And where screening stands today, all cervical cancer screening approaches, be it PAP, VIA, or HPV, face common challenges to successful implementation on a large scale. Any disease can be controlled provided we adopt a strategy that suits our country, relates with our disease numbers, and whether we are dealing or we are targeting with at the classes or the masses. Likewise, we should choose the test, but we must ensure all in all the unparalleled success of the past is carried forward into the future. Now, vaccines is a topic by itself, but it is a very big hope in controlling this disease and will definitely reduce the burden of the disease and naturally the burden on all these tests, and so the cost of the test will gradually come down and they will be easily available to the masses. Vaccination drive for girls before starting sexual activity is already picking up very well in the public who can afford it, and it needs to be boosted up by lowering the price of these vaccines. Now, till then, the prices come down. What is the desirable approach for our rural women? The need of the hour is to train our paramedics for information and education of the rural women and doing a VIA, and they should be able to train them to do a VIA or a PAP. That is important. Persuade women to accept screening. That is a challenge both for the gynecologist and for any health worker. And ask the women, persuading them to return for rescreening and diagnostic test. And the realistic approach for mass screening in India, I personally feel with all the experience of the last 20-25 years, that every medical college should have a dysplasia clinic, which is very well equipped. There are a lot of problems with these dysplasia clinics. Sometimes the colposcope is working, sometimes not. We do not have enough hands. But if all these are made available and we give enough strength to the opportunistic screening that can be done wonderfully in our clinical OPDs, which are very heavy, and if these clinics come under the MCI norms, then we can really catch a large number of patients. And these dysplasia clinics should be existent in all district hospitals and corporate hospitals. A PAP and VI clinic for women should be made existent in the rural hospitals and PHCs. And CA cervix is now an established sexually transmitted disease. So why not combine all the efforts against STD, AIDS, and cancer cervix? Why do disjointed services in these directions and disperse the funds in various directions? So we can take cancer cervix under the one umbrella of STDs and AIDS, then we can give this test as a part of detecting STDs. Thank you so much.